Hi, everyone. Thanks for joining us. My name is Joanna Kempner. I'm a sociology professor, and I study health and social justice. I always begin my classes at Rutgers by explaining that disease is never just a biological phenomenon. It's always social, political, economic, and cultural. This year, I think I might just have the pandemic teach my class for me. The pandemic has revealed deep structural problems and profound inequities in American healthcare. But in doing so, it's also produced opportunity for us to build a more just healthcare system. So over the next 10 minutes, I'd like to provide a framework for understanding how gender bias operates structurally and ensuring that women, and especially Black women and women of color, are systematically underserved by our current healthcare system. Gender bias is endemic and pervasive in contemporary medicine, and this gender bias is made all the more complex and dangerous when mixed with additional structural advantages like racism, xenophobia, homophobia, and transphobia. So I'm going to be highlighting the following points. Women's diseases are stigmatized. We don't know enough about diseases that disproportionately affect women. And we don't have enough policies in place to support women who are disabled by these diseases. So on to the first point. Women's diseases are stigmatized. Women and women's health have been long systematically ignored in Western medicine. And I could talk for a long time about why and how this has happened and its many manifestations. But for now, let's just focus on this one single point. When women are in distress and they go to their physicians or they go to their friends and families and employers, they're often disbelieved and sometimes even belittled. This experience happens so often, we now have a term for it: medical gaslighting. Many of you will be familiar with this phenomenon. For me, it started when I was just a little girl. A pediatrician diagnosed my own recurring headaches as a symptom of a type A personality. That might sound silly, but these slights continued. A psychologist once even suggested that I get a boyfriend as a treatment for my migraine, evoking that old canard that women with headaches are simply frigid. Research suggests that I'm not alone in my experiences. Women with myalgic encephalitis, chronic fatigue syndrome, report that they must work hard to be considered credible patients. Women with fibromyalgia talk about the constant delegitimation of their symptoms, and how being constantly delegitimated makes them question their own experiences. And that happens with migraine all the time too. If you're constantly told that what you're experiencing isn't real, people start to think like maybe they are making it up, maybe they are feeling crazy. And all of these experiences are compounded for Black women and women of color. For Black women particularly, Black women with invisible diseases have to fight multiple stigmas simultaneously. The pervasive stigma that Black women are all on welfare or seeking drugs, the continued misperception that people of African descent don't feel pain, and then completely counterintuitively, a pervasive misconception that even when Black women do feel pain, that they are so accustomed to pain that they can deal with it, so then therefore don't need treatment. So now, not surprisingly, I'm reading reports that women experiencing long-term symptoms, including headache and migraine, because they have had COVID for months on end, that they too are having trouble getting doctors to believe their experiences. So these gendered stigmas are deeply ingrained in our culture. And I'm just going to show you some ads from the past. Some of you will kind of be familiar with some of these. We sometimes think about these old sexist ideas as something we left behind in the 1960s. So something like this ad, right? This is an ad for an old headache medicine for Anacin, actually. When boredom and emotional fatigue bring on the housewife headache. And here you have a housewife, and she looks so listless. She's thinking about her ironing and her dishwashing and her groceries and carting around her children. And boy, do I know how she feels. But then she takes Anacin, and you can see here, she's ready for a date with her perfect, handsome husband. So you have the before and after picture with the medication. It's so easy to treat. And she gets to, she's ready and sexually available. But that's an old idea, right? Well, not necessarily. We still have those ideas. This advertisement is a little bit, it's 21st century advertisement for headache medicine. And here, the woman's at work. She's not a housewife, but you can see she's still in a caring duty, something that we consider feminine. She's nursing. She's not nursing just anybody. She's nursing babies, something that we think about as, again, a feminine duty. And if you can see in the sort of before shot, she is having a migraine. She's taking that migraine pose, which is like, oh, I'm thinking so hard. Where are my keys? And she's turned her back to the babies because when she has a migraine, she can't take care of the babies, or she doesn't want to. It's not really clear. But she takes the medicine, and in the aftershot, we can see the nursery becomes a light, bright, happy place where she can give that baby the individual nurturing that baby deserves. She can be restored to her feminine self. So these ideas about gender and femininity are so ingrained into our culture, even still. Even though we have some new, better medications, we still think about women in this particular way. That when they are in pain, when they have migraine, if they're white women, they just cannot, it's just something that keeps them from doing their womanly work. Now, had I had the time, I would show you more imagery and language, some pulled straight out of medical textbooks, which clearly illustrates that sexism is also deeply ingrained in medicine and in our very policies themselves. But I believe you'll be hearing some of that from some of our other panelists. Now, these stigmas matter because they are deeply embedded in our institutions, from NIH to medical hospitals where education happens, to places of employment where women with chronic illnesses often find their ability to work curtailed by stigma and discrimination, and maybe even especially at home where women have to face disbelief even from their own families. Now, addressing sexism in these arenas matter, not only because they limit what we think of as normal and what we think of as acceptable, but because they limit what we imagine as possible for women and for our own daughters. Okay, next point. We don't know enough about women's diseases. In the United States, medicine began excluding women from its ranks in the mid-19th century. Now, prior to Congress passing Title IX legislation, fewer than 10% of medical students were women. After that, and now actually in the last few years, we've had over half of medical students become women. So it took legislation for that to happen. The Office of Research on Women's Health was only set up in the 1990s, and it was only because of the NIH Revitalization Act of 1993 that we started seeing the inclusion of women in clinical trials and women and minorities in clinical trials. Now, these efforts have improved women's health, but they don't do enough, or actually they do very little, to actually direct attention to diseases that predominantly affect women. So I'm going to show you why this matters in this following chart. So this chart looks at how NIH allocates funding to various diseases by what's called a DALY. DALY is an acronym that stands for Disability Adjusted Life Years, and it's a way of measuring the burden that diseases cause across various diseases. One way to see if NIH is allocating money to diseases fairly is by coming up with a standard measure and then seeing how various diseases fall in terms of how much money they have. Now, on the y-axis, what you see here is how much money NIH allocates to these various diseases. And these are the various years, 2010, 2013, 2015. The red dot is how much money NIH is giving to migraine. The green dot is to headache. And what you can see is these blue dots are other money allocated to other diseases by DALY. And this diagonal line would be the regression line, the predicted amount of funding a disease should get. And what you can see is that migraine is falling far, far below these other diseases. So if this line here shows you what arthritis is getting, breast cancer, and digestive diseases, they're all getting far more money given how much disability they cause. So migraine is systematically being underfunded. This is a logarithmic chart, so the gaps you see here are actually much larger than they appear on this slide. Oops, sorry. Okay. So these are gross funding shortages, and the reason they matter is because they have massive downstream effects in medicine. Diseases that consistently don't receive NIH funding typically won't receive new treatments. They don't attract many specialists because specialists are the ones who are doing research, and university hospitals aren't going to hire areas and that don't get funding because university hospitals depend on that funding. And that means that people who have these diseases are going to have less access to good care. There are currently fewer than 600 headache specialists for the 40 million Americans with migraine. So as a result, fewer people with migraine are going to receive treatment. There was one study that was done that showed that only 5% of people with chronic migraine receive a correct diagnosis and correct treatment. And that doesn't even mean that those people getting that treatment are getting better. And that, I find that very alarming. So why doesn't the NIH fund these diseases? Sociologists have done work in this area, and their work shows that diseases affecting stigmatized groups don't receive as much funding as other diseases. My own research on migraine strongly suggests that NIH isn't interested in funding migraine because it's just not seen as a serious disease. We might also consider who's reviewing these grants. Are they men? Are they women? Do they themselves conduct research in these underfunded areas? Do they represent other demographic groups that are really studied? Which brings me to my next point. We don't have sufficient policies in place to support women who are disabled by these diseases. Women do live longer than men, and this is a gender disparity that doesn't get talked about very much. But we also know that women experience many more disabling diseases than men. In addition to more research, we must always remember that there's more to women's healthcare than biology. Women are not simply different than men because they have ovaries. Women live different kinds of lives. Women already earn less than men, so it's worth wondering whether women's increased rates of disability exacerbate this wage gap. Women tend to be the primary caregivers in their families, so it's worth asking what happens to families when women are disabled. And during this pandemic, women, and especially women of color, have been out on the front lines working as nurses, teachers, and other essential workers. What will we do if women are more susceptible to long-term disability post-COVID? We can support women by supporting their ability to live whole lives, whether or not they have an illness. As it is, only 36% of women with chronic migraine are able to go to work. When women cannot get to work, when women cannot care for their families, entire households experience downward mobility. We also know that our social safety net for women with chronic illnesses is broken. The Social Security Administration prohibits patients from supporting their applications for disability with symptom reports, but migraine has no reliable diagnostic physical signs or laboratory findings. It's an invisible disease. As a result, SSDI claimants for migraine have among the lowest participation rates relative to its disability burden. I worry about these families who cannot access basic supports. Their loss is devastating. But I also think about what our country loses when we don't support women with chronic illness. The ingenuity, creativity, productivity, and joy of tens of millions of women and their families. We can do something about this. The pandemic has, by necessity, required us to find creative solutions to gaps in social policy. Congress has an important role in formalizing policies that will help women and families in the long term. Thank you.